Welcome to the Hepatitis and HIV Virtual Education Summit Series, presented by Johns Hopkins University School of Medicine at ID Care Live. My name is Dr. John Reines, and you are tuned in to a live session called Managing Hepatitis C in Patients with Advanced Liver Disease with Dr. Robert S. Brown. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. Dr. Brown is the Chief of Medicine and the Medical Director of Transplantation at Columbia University College of Physicians and Surgeons. Dr. Brown?
Thank you, John. I think you just gave me a promotion. So it is my pleasure to be here this afternoon to talk about treatment of hepatitis C in patients with advanced liver disease. I want to start with the introduction that we know that hepatitis C can be treated in patients with cirrhosis, provided that they're compensated, and I'll show you that data later on. However, in clinical trials, the exclusion criteria eliminated all patients with advanced disease or any degree of decompensation. So we have to question, first, what is decompensation? Certainly ascites and encephalopathy would classify as advanced liver disease, as would bleeding varices, though many patients with cirrhosis will have varices on endoscopy that are not clinically apparent, and we're not certain where those patients fit in. But given that many of those patients would be excluded based on their platelet count alone, we know that data in patients with portal hypertension is extremely limited. Now, when we talk about treatment of advanced liver disease, I think we have to do it only in the context of liver transplantation. Until we get to interferon-free therapy, treatment with interferon-based therapy in patients with decompensated liver disease or portal hypertension should only occur in the context of a transplant plan. We do know that successful pre-transplant treatment with eradication of the virus will prevent post-transplant recurrence. And given that post-transplant recurrence is the major cause of morbidity and mortality for Hep C patients undergoing transplantation, it's valuable. The question is it worth the risk? And that has two components. First, a lower likelihood of response due to a decreased responsiveness even in earlier phases of cirrhosis, and with the thrombocytopenia, neutropenia that we see in cirrhotic patients, less likely to tolerate interferon doses. The second element is increased toxicity. Infection, neutropenia, spontaneous bacterial peritonitis all can occur in interferon-based therapy. And liver decompensation has also been reported, and I'll review the data on that. So in our program, living donor liver transplantation is one of the only ways that you can actually treat patients with decompensated disease with that safety net that you know you can do a liver transplant. So for a long time, there was no interest in treating patients with advanced liver disease until the Colorado group, headed by Greg Everson, published this paper on the low accelerating dose regimen, or LADDER. This was a regimen where he started with a low dose of interferon and ribavirin and escalated the dose. It's important to remember this was just dual therapy with pegylated, or initially standard interferon, eventually pegylated interferon and ribavirin. What you can see is out of those 124 patients, about half responded to therapy, but unfortunately, half of them relapsed after therapy was stopped. So at the end of the day, only 25% were able to clear Hep C. This is all genotypes, much lower than what we expected at 54% with standard interferon or pegylated interferon and ribavirin. And what you can see when you look by genotype is that genotypes 2 and 3 had a high rate of clearance on therapy, 80%. Genotype 1s, only about 30%. But the relapse rate was much higher than in the non-cirrhotic population, almost 50%. So SVR was achieved, or virologic cure, in only 50% of the genotype non-1, as opposed to 70 to 80%, and only 15% in the genotype 1. But what led people to say maybe this is worth something was this one small subgroup of 15 patients who underwent transplantation while on antiviral therapy with a negative viral load. And you can see that 12 out of those 15 patients, or 80%, remain negative after transplantation. So if you go back to the fact that almost over 50% could be cleared on therapy, it raised the question that we could cure anywhere between 40 and 60% of our patients if we did a transplant on therapy. But there was an important caveat, and that was that many patients had serious adverse events, including ascites, encephalopathy, bleeding, and worsening of diabetes. And 4 out of those 124 patients died. And so the question was raised, is it worth the risk? And this was studied in a large randomized controlled trial that we carried out with 8 other centers in the A2ALL, or Living Donor Liver Transplant Consortium. And this has been published in Hepatology. In this study, genotype 2-3 patients were all assigned to treatment because it was felt unethical to randomize patients with such a high response rate. Genotypes 1, 4, and 6, we felt we could randomize 2 to 1 so that we would have a safety cohort with control patients. We only considered patients who had either a living donor for a living donor liver transplant or who had the increased priority given to patients with liver cancer, or HCC, because these patients had less severe disease and we could predict the time of transplantation. So this is probably the best cohort of patients on the transplant waiting list. And so we did include sicker patients. They could have a MELD score up to 20, a creatinine up to 2.2, platelet counts over 35,000, and neutrophils over 750. So of the 79 patients, you can see that a large proportion of genotype 2-3 patients chose to participate, and they were mostly treated. The other patients were randomized. And we had much more disappointing results. Rather than the 80% of 80%, we had a 40% of patients who were genotype 2-3, and only 18% of genotype 1 patients who, after transplant, were cured using an accelerating dose of pegylated interferon and ribavirin right up to the time of their transplant procedure. Now, when you looked at the duration of therapy, clearly duration mattered. You can see that if you had less than 10 weeks of therapy, you didn't do quite well. On treatment, it rose to about 70% could achieve a negative viral load at the time of transplantation, and that the risk of relapse fell from 65% with less than 10 weeks to about 30% if you could get more than 15 weeks. So if you got more than 15 weeks, you had a reasonable chance, 44%, of being cured post-transplant. And when we looked at the predictors of post-transplant viral response or post-transplant cure, only the duration of therapy mattered, not the genotype, baseline level, whether they had a living donor or a deceased donor, whether they got to their target levels, or whether they used growth factors. Now, were there adverse events? Yes, there were, and this is why it's so important that we had the untreated control group in light blue. Because though you can see that adverse events and serious adverse events were more common in patients treated with interferon. They were pretty common on the transplant waiting list, and the death rate of 14% was not different whether you received or did not receive treatment. But these adverse events not only occurred at a higher rate prior to the transplant, they occurred at a higher rate in the first 30 days, and though they got closer after 30 days, they continued to occur at a higher rate in patients on interferon. Now, some of this may be an observational bias because it wasn't a blinded study, but it raises the question that that long-acting interferon may play a role well after the transplant. And many of these were due to infections, which occurred much more commonly in treated patients than untreated patients. Now, obviously, you can see there is a little bit of a bias here because I've never been in a transplant where we had no infections in the first 30 days. But you once again see an increased rate in all transplant periods in the treated patients compared to the controls. Now, we're out of the dual therapy mode. We're currently in the triple therapy model and moving towards interferon-free therapy. So the question is, how can we do better, both today and eventually in the future? For the current time, where we still need interferon and ribavirin-based therapy, it's important to remember two things. Ribavirin is very sensitive to renal function, and patients on the transplant waiting list are very prone to renal dysfunction, and we need to maintain good renal function. Methods to maintain blood counts are not clearly used. Outside the U.S., splenic artery embolization has been used to improve the blood counts. The use of growth factors, EPO, GCSF, L-thrombopag, and other thrombopoietin analogs have also been done. Mostly EPO and GCSF due to the warnings about L-thrombopag and portal vein thrombosis, which concerns many clinicians. We also probably, in this interim period, need to do better shot selection. If you could predict who would be in that 40%, those patients are getting a big improvement in their outcome. If we could do a better job of selecting who's in that group and then not treating the other patients, that would be better. But I think all of us, certainly me and you, are looking forward to interferon-free regimens, perhaps also ribavirin-free regimens, which don't have substantial bone marrow toxicity and would be able to be used in more patients with advanced disease. But until we get to that, it's important to look at the current standard of care for genotype 1, which is protease inhibitors, of which we have telaprevir and boceprevir. Now, as I said, there were no patients with decompensated disease in the registration trials, and we already saw that patients with advanced disease had a lower SVR rate than those that didn't have advanced disease. 79% for patients with mild fibrosis, only about 60% for those with cirrhosis. And though the difference wasn't seen in relapse patients where cirrhotic patients had the same response rate, you could see that for partial and null responders, which are a large part of our transplant practice, you see a huge drop-off in the response rates when you go from F0 to F4, with the F4 null responders only having a 14% cure rate compared to 40% for those with mild fibrosis among the null responders. And when we look at boceprevir, you see the same trends. Lower response rates, both to triple therapy, to response-guided therapy, and to fixed duration therapy when you go from the mild fibrosis to the patients with advanced or stage 3 or 4 fibrosis. Stage 4 fibrosis being cirrhosis. So if our response rate's lower in patients with early cirrhosis, we have no idea how low it will be in patients with advanced liver disease. And some attempt to answer that came from the CUPIC study, which was a study of patients, an open access program in genotype 1 cirrhotic non-responders in France prior to general approval of either telaprevir or boceprevir. It's important to know that they used fixed duration therapy with either 12 weeks of telaprevir, peg-ribavirin, and then 36 weeks of peg-ribavirin, or a 4-week lead-in for boceprevir, and then 44 weeks of triple therapy. And when you looked, patients who had more advanced liver disease, either a platelet count under 100,000 or a serum albumin under 35 grams per deciliter, or 3.5 in our units, had a much higher rate of severe complications, defined as death, a serious infection, or hepatic decompensation. And if you had both of those factors, the rates were even higher. Once again, highlighting the pitfalls of therapy. Now, the response rate on therapy was actually very good, but because of the high rates of discontinuation, the SVR rates, which have been recently produced, are quite low. But this was not done in the context of transplantation. So when you look at transplantation, I wanted to highlight our protocol, which has been used by many centers doing transplant with triple therapy. And what we do is we select those same patients we did in the peg-ribavirin ladder protocol, and we use a lead-in, and then we use ribavirin, and we also do an accelerating dose. We give all our patients with portal hypertension prophylactic antibiotics to prevent SPP, and then we give them a protease inhibitor. And based on the data showing that you needed at least 15 weeks of therapy, we activate the patients at 16 weeks or when their viral load has been negative for 12 weeks, whichever comes first, usually 16 weeks. And though the data is small, you can see we've only treated 28 patients. Of those on therapy who've been transplanted, so far 6 out of 8 remain cured post-transplant. And if you look at the rate of clearance, 20 out of 28 are able to clear virus on therapy, which if you look through this and try to calculate what the likely SVR rate, it'll be somewhere between 60 and 65%. So a little higher than what we saw with peg-riba for genotype 1, but certainly not where we want to be. So let's turn our attention to the future. The future is all oral therapy. I've chosen to highlight sofosbuvir because it has a clinical trial in patients on the transplant waiting list, though I could show you a variety of all oral therapy and it would be equivalent. And so sofosbuvir has been studied with peg and ribavirin in genotype 1 and in small phase 2 called Electron without interferon in genotype 1. And you can see they had a treatment naive and null responder cohorts, and then they've given those patients combination therapy of sofosbuvir and ledipasvir, or an NS5A inhibitor, or their non-nucleoside inhibitor, GS9669. And what you can see is, though sofosbuvir and ribavirin had a reasonable SVR rate, 84%, in genotype 1 naive patients, in genotype 1 null responders, the SVR rate was only 10%. But as you see, the end of treatment response across the board in all of these arms was 100%. So if we could do a transplant on therapy, this highlights that perhaps we could get up to 80 to 100% of our patients being cleared after transplant, even with sofosbuvir and ribavirin, never mind more potent combinations that may come to pass. And as we've seen recently, and I hate to put out a press release, but because this is of interest, you can see that even in patients who have seen a protease inhibitor, have compensated cirrhosis, the possibility of 2 or 3 drugs in 12 weeks to clear the vast majority of genotype 1 patients is in the future. And whether we choose this regimen, the regimens from Abbott, BI, Bristol Myers Squibb, the number of new agents highlights that the ability to get patients to transplant with a negative viral load or even cure them prior to transplant is in our future. So what is the data on interferon-free therapy pre-transplant? The answer is none right now. There is only one trial, which is sofosbuvir and ribavirin in pre-transplant genotype 1 patients only with either a MELD upgrade for hepatocellular carcinoma, like the study I showed you, but excluding living donor patients. Because we know that for prior null responders, that this regimen is probably inadequate. At the current time, I would say we need either a timed transplant or the ability to give these medications long-term, or the knowledge that we can achieve SVR in patients with advanced liver disease, none of which at the current time is known because we have no combination therapy DAA agents or data available to date. But, and I think it's important, I'm an optimistic guy, that the wide variety of agents from various companies I think raises high hopes. But we have to remember that until we have the data, we don't know a lot of open questions about portal hypertensive patients. So where are we at the current time? I think we have promising interferon-free therapy, but still we have no proven regimen of interferon-free therapy, really even in early cirrhotics, never mind cirrhotics with portal hypertension, prior non-response to multiple agents, the more difficult genotypes, 1A and maybe even genotype 3. But for today, I think the higher rates of viral negativity on treatment may increase the value of either a living donor or in patients in whom you can predict the time of transplant, a deceased donor transplant, while on therapy. But we still have a lot of open questions. How well will these new agents work in patients with decompensated cirrhosis? Will we see decompensation with oral therapy? We certainly see it with hepatitis B with eradication on occasion. Maybe there is an immune clearance, or maybe it's just the interferon. We like to hope it's just the interferon, but time will tell. How long will we need to treat decompensated cirrhotics? Is this an area where maintenance therapy will be needed up to the time of transplant? Or will we be able to have curative treatments? And what will the toxicity be when we move from early cirrhotics to more advanced cirrhotics to those with hyperbilirubinemia, impaired clearance, and other things that we see in advanced liver disease? I think despite the open questions, I clearly feel that the future is a lot brighter than the present, which is still a lot brighter than the past for hepatitis C and transplantation. I'll thank you for your attention, and we'll take some questions.
Thank you very much, Dr. Brown, for a really interesting presentation at a very interesting moment in the history of care of viral hepatitis and care of viral diseases in general. While we're waiting for some questions to come in from our audience, I thought maybe we could go back and put ourselves in the position of some of our referring doctors and review for them what the management in general is of a patient with hepatitis C who has advanced liver disease. What are the steps that we should be taking in order to evaluate them and make sure that they have the best possible chance at an outcome?
Well, that is a critical question. I think that the need for cirrhotic healthcare maintenance falls into two parts. First is what's needed for all patients with cirrhosis. So that is hepatocellular carcinoma screening, which is imaging every 6 months, and we could debate what type of imaging needs to be done. It comes down to cost, degree of radiation, and sensitivity. I like to use a mixture of ultrasounds alternating with mainly MRIs every 6 months. I think the interval clearly has to be 6 months. I use alpha-fetoprotein. Even though it's not been in the AASLD guidelines anymore, I think that as long as you don't overinterpret the alpha-fetoprotein, meaning using a normal one to reassure yourself, or an abnormal one to lead to over-testing. A stable alpha-fetoprotein is reassuring but not a guarantee of no cancer. A rising, progressively rising alpha-fetoprotein is clearly a concern. And then all of our patients with Hep C should be cautioned on weight loss, alcohol cessation, and probably better control of diabetes. And then I like to replete their vitamin D. I think the data on vitamin D is intriguing, and certainly bone disease is common. And then vaccination for hepatitis A and B if they're not immune. So that's for every patient with cirrhosis. For compensated cirrhosis, that's all. For decompensated cirrhosis, which would be defined as either a child's class of B, a MELD score of 10, or the presence of ascites, encephalopathy, or an index variceal bleed, I think that's when a referral to a transplant center should occur.
What about the use of endoscopy to screen for esophageal varices?
Well, clearly our society guidelines recommend in all compensated cirrhotics an index endoscopy, and if there are no varices, repeating that every 2 years. Whether you should take someone who has cirrhosis on biopsy, who has a completely normal platelet count, and do an index endoscopy, I think we can debate. But certainly when the platelet count is under 150,000, the likelihood of varices being there is substantial. And we know that beta blocker prophylaxis will reduce the risk of bleeding. And since primary prophylaxis for bleeding is effective and inexpensive, I would recommend an index endoscopy. At what platelet count do you start, recommending your patients have an index endoscopy? Let's say they have cirrhosis on a biopsy 3 years ago, but their platelet count's 200,000.
No, I don't think that we would go ahead and scope that patient, but as soon as there were signs that there was portal hypertension, then we would do the index endoscopy. What's your feeling about primary prophylactic banding?
I don't do a lot of primary prophylactic banding. I think the data saying that it's superior to beta blockers is pretty limited. It's obviously much more invasive. I think if patients don't tolerate beta blockade or have a contraindication to beta blockade, or you put them on a beta blocker and when they get a follow-up endoscopy, they have enlarging varices because they've been getting worse, I think that you can make a case for prophylactic banding. But I just think that in the realm of therapies that can cause complications, the data just isn't strong enough. Now, secondary prophylaxis after an index bleed is clearly indicated, has been shown to reduce rebleeding and likely reduce mortality. And that's not just banding them at the time of bleeding. It's follow-up endoscopy, which then has to be done for life.
How do you approach a patient who's found to have gastric varices on the index endoscopy?
Oh, that's a tough one. I mean, I think beta blockers, yes. I don't think there's any role for prophylactic banding. And then I think worry. I think gastric varices are certainly much more difficult to manage. They can get bigger, obviously, if you band esophageal varices, which I think is certainly if someone has big esophageal and gastric varices, banding their esophageal varices prophylactically would be a mistake. I don't know what to do other than fret. And if they have other indications for a shunt, for a TIPS procedure, knowing they have big gastric varices might decrease my threshold for doing an early TIPS.
What is your threshold for doing a TIPS? For example, we know that the MELD score was initially developed to predict mortality after a TIPS procedure, and yet the patient with the highest MELD score is the one who is most likely to need the TIPS procedure. So how do you go about timing that intervention?
Well, that's challenging because as we've gotten better at managing so many complications, particularly bleeding, the use of TIPS for bleeding has gone way down. The use of TIPS for ascites is going up. And the problem is the most refractory ascites patients are also those that tend to have the higher MELDs. I don't know the right answer. I like to view that my simple rule is Billy under 3, okay. Between 3 and 5, you better have a really good reason. And above 5, I don't think you can do the tip safely. Have we done it in certain situations where we have no other options? Yes, but I think large volume paracentesis, aggressive banding are probably safer for the patient in the long run.
Getting back to the question of hepatocellular carcinoma, only a few years ago, this was considered to be a uniformly fatal disease. But you've explained to us that a lot of transplant is now done in patients with hepatocellular carcinoma. Do you want to expand on the management of hepatocellular carcinoma?
That's been something in evolution. When transplant was first invented, we used it only for cancer because we couldn't justify doing that procedure in patients who had just liver disease. The outcomes were too poor. And then we had high rates of cancer recurrence, and it was sort of abandoned for a while. Then what was found is that particularly in patients with hepatitis C, we would take out the liver with no suspicion of cancer, and they would have small incidental hepatocellular carcinomas. And they had a very low recurrence rate. And that, combined with the ability to do local regional therapy, chemoembolization, Y90 radioembolization, radiofrequency ablation, a bunch of other ablations that I won't go through all in detail, the ability to control tumor and do a transplant raised the interest. And that led the Italian group in Milan, to develop criteria that predicted a low recurrence rate. And we use those Milan criteria, which is a single lesion less than 5 centimeters or 3 lesions less than 3 centimeters, to not only view as an indication for transplant, but we give them added priority to hasten their transplant. And they do quite well, and they are an increasing proportion of our transplant population, because as the Hep C generation ages, we're seeing a rising rate of cancer. As people do better screening, we find small tumors, we accelerate their transplant, and in some regions of the country, up to a quarter of the liver transplants are done in patients with Hep C and HCC, which is an astounding high number. And there's a lot of debate as to whether we should change the criteria, some saying we should allow in big tumors, some saying we should less tumors, lower priority, and I think all those are controversial. But what isn't controversial is that if we do good screening and find cancer at an early stage, we can transplant these patients successfully.
I'm often asked by referring physicians why we aren't biopsying patients to document the diagnosis, or sometimes physicians will biopsy patients and then send them to us. What are your feelings about that?
Well, there is now a consensus both in the European Liver Society and in the American Liver Society that biopsy is rarely required. And the reason is twofold. One is that these tumors have specific characteristics on a well-done contrast-enhanced study, which would be either an MRI with gadolinium or a true 3-phase CT scan, because they have early enhancement, because they have arteriovenous shunting, they have what we call portal washout, which means when the rest of the liver is becoming bright, they are becoming darker. And then they have, because they are hepatocytes, in the venous phase, they become isointense. We know that biopsy has a false negative rate, where the biopsy is benign because a well-differentiated HCC will look cytologically very similar, but structurally different. And so people can be reassured. That, combined with the risk, because you have to do a core biopsy, not a fine needle aspiration, and the possibility of needle tract seeding, has led to a lack of interest in biopsy, because it's not going to increase the likelihood. Is there an occasional false positive to MRI? I'm sure there is. But if you have a lesion that has these imaging characteristics, particularly one that wasn't present, is now present and confirmed, you will know. And certainly in a transplant candidate, you'll have an opportunity to observe that patient on the waiting list. So do we biopsy lesions? I biopsy lesions in patients who have either diffuse disease where they have no other options. I biopsy patients who would not be a good candidate for transplant, in which I need to be 100% certain. But the incidence of biopsy is rarely required, but is useful in very certain circumstances, particularly if the imaging is non-conclusive. But in general, since these are slow growing, time is your friend, and time can take the place of biopsy.
We do have a question from the audience, and the question is, how do we determine that a patient has been cured of hepatitis C virus infection?
That's an excellent question, and I'm glad somebody asked it, because I use the word cure because we believe in cure. We used to use the term sustained virologic response, meaning that the virus was undetectable 24 weeks after therapy. Now we know from way back to the interferon monotherapy days that if you were negative 6 months after therapy, the chance of having virus 5 to 10 years later is less than 1%. And to me, that's equivalent to cure. Now, there is some data that says you can predict that 24-week SVR at 12 weeks. We call that SVR 12. And probably SVR 12 is also cure. It is not so clear that the viral response 4 weeks after therapy, which is now called SVR 4, is equivalent to cure. But I think SVR 24, definitely. SVR 12, probably. SVR 4, maybe.
Another member of the audience would like to know if you believe there's any connection between smallpox vaccination and the spread of hepatitis C virus infection.
I'm going to have to ask you. Certainly there have been spread of hepatitis C through a variety of vaccinations, usually not because of contamination of the vaccine, but because of reuse of the needles. The schistosome vaccination program in Egypt is probably the prime example of that. Many have said that the smallpox vaccination program that occurred in U.S. veterans contributed to the higher rate of spread in that group of patients. I was one of those people who stood in the gymnasium and got the gun, used one after another. Fortunately, I was probably in a clean gymnasium. But I don't know the answer to that question. Do you have any data on smallpox vaccine?
I think that the most important aspect of this is that we like to know, if we can, how long a patient has likely been infected with hepatitis C virus, because we have very good natural history data about the progression of the disease. And so if we can date the infection to a specific event, that gives us some confidence that we can predict the likelihood of the patient's outcome possibly 5 or 10 years down the line, which of course is always very difficult. And I'm sure you have the same experience, which is that we see a lot of patients who've moved to the United States from other countries where healthcare practices might not have been as closely monitored or as carefully controlled, and where supplies of paraphernalia might not have been as good. And there's a lot of these people I've always suspected have gotten hepatitis C as a result of a iatrogenic exposure.
I'm sure that's true. Also unscreened blood supply, there are still countries where the blood supply is unscreened. So I think it is important, actually. Just today, the recommendation for age-based screening of the baby boomers born between 1945 and 1965 got upgraded in its recommendation to grade B, which means that hopefully this will now become part of meaningful use and our common practice, because many patients have unknown risk factors. Because whether it's a vaccine, iatrogenic, tattooing, a whole variety of potential bloodborne exposures, risk factor-based screening has failed in the United States. And I'm very glad that we're going to now move towards age cohort-based screening in that group of patients. But I also screen anyone who was born outside the United States, or particularly those that had their early childhood where they were vaccinated or gave birth. You know, we see a lot of patients at Columbia from the Dominican Republic, women who probably were transmitted iatrogenically during childbirth.
So we would like to, I think, emphasize the CDC recommendation for age cohort screening in current medical practice.
I think that now that it's been adopted by the U.S. Preventive Health Task Force, we may see wider acceptance of that, and certainly it's our approach in our practice, and I would like to see it in the audiences as well.
Do you believe that every patient who has hepatitis C should be treated?
I think that time will come. We can always debate in an era of cost containment who's too old, who's too sick. But I think there are a few things that are clearly true. One, it's better not to have hepatitis C than to have it. And two, the sooner you could cure it, the better. And so when we have all oral therapy with few side effects that is very effective, it really will come down to cost. But I think that in patients who have a reasonable life expectancy, the answer isn't whether we should be treating them, it's when and with what. And so I do think that we're going to get to a point of near universal treatment. But even in this interim period, there are simple things you can do for someone who screens positive. You can advise them on alcohol. You can vaccinate them for A and B. You can advise them on the low but possible risk of transmission to their family, particularly their sexual contacts. And so I do think that there are important things that we can achieve in every Hep C positive patient, even if we take treatment off the table.
So how do you then make the decision to treat somebody who you suspect has advanced liver disease and might be of an age where they're likely to develop complications at some point in the future, at this point in the treatment paradigm?
I think that's the most difficult situation, probably why you're asking me. The answer is, I think right now with therapy in flux, you disconnected from the internet. With therapy in flux, I think you have a situation where treatment is clearly going to get better, but they will progress. Most patients, I think, today can wait for newer therapies. But if you look, right now we're treating under 5,000 patients per year. We have 3 to 5 million Hep C positive patients available. Even if we get to 150,000 patients treated per year, we're going to be doing this for the next 10 years. So if I have a very motivated patient who wants treatment today, I think given the high cure rates, if I think it's safe, I will undertake it today. If it's either not safe, or the risks are higher than the potential benefits, or the likelihood of response is low, I think I recommend deferring till tomorrow. But obviously, patient motivation is clearly a factor because we do have approved therapies that have a high response rate and, despite their toxicity, can be used successfully in a lot of patients. And if you cure them today, it's better than curing them tomorrow. But I think that's a very individualized decision. And I think for patients, I think they have to know that, one, there are good therapies today. And yes, there are better therapies tomorrow. And so whatever they choose, there really are no right answers.
Do you see therapy moving out of the gastroenterologist and the hepatologist's office in the near future?
I think so. I certainly think that infectious disease doctors, when we get to all oral therapies, will do this. I think that if you have a motivated primary care provider who has enough patient volume, I would think substance abuse clinics, inner city patients who have poorer access, if they take the time to learn, we're going to have a variety of regimens. They may be different for different genotypes and even genotype subtypes. It's a question of expertise And also, very importantly, knowing that you have to know the stage of disease, and that if the patient has cirrhosis, even virologic cure, it may prevent decompensation, but will not reduce the risk of cancer to zero. I think over time it will reduce it somewhat, but it will not reduce it to zero for the foreseeable future. So what my worry is as treatment becomes broader, it has to be accompanied with a knowledge of Hep C natural history, and so that these patients are not cured of their Hep C and die of their liver disease anyway.
What is your approach to staging patients?
Well, the gold standard is still liver biopsy. I think that hopefully with the advent of elastography, which was much more specific for advanced fibrosis, eventually we can get rid of biopsy. The problem is that serum markers are very good at differentiating no fibrosis or mild fibrosis, but we need a way to differentiate advanced fibrosis and the need for liver cancer screening. FibroScan was just approved by the FDA. We'll see how quickly it gets out into clinical practice. But until then, I think you need to make an assessment. And I think in certain patients, it's easy to say, no. Younger patients, less duration of disease, normal platelet count, perfectly normal imaging, probably don't have cirrhosis. Older patient, low platelet count, nodular liver, they don't need a liver biopsy either. They have cirrhosis. It's those patients with long duration disease, borderline platelets or low normal platelets, where I think those patients need some assessment, whether that's biopsy or a non-invasive marker, I think remains to be determined. But what you cannot do is just assume they're okay and then treat them, cure them, hopefully in the future, and then just not do anything else. And as a healthcare system, we can't afford, nor would it be cost effective, to do HCC screening on every patient with Hep C who we, forever.
So if you had the opportunity to give advice to a general practice physician or an infectious disease physician about how to approach treating patients with hepatitis C, what would you tell them?
Well, I think first, we have to do a better job of screening. And then confirming the antibody test. Of course, our screening test is a single, one-time HCV antibody, which is positive for life, even if you clear virus, so it never needs to be done again. You confirm that with a viral load and a genotype. You make some assessment of disease severity. If they're cirrhotic healthcare maintenance. If they're non-cirrhotic, decision on treatment based on their genotype, their motivation, with or without an affiliation with a gastroenterologist, hepatologist. I think all Hep C treaters, whether they be primary care providers or infectious disease doctors, will need at least some affiliation with a gastroenterologist, hepatologist to manage advanced disease. And then for those with less advanced disease, if they have the expertise, I think once they learn about treatment, this can easily be done in their practice. I think we're going to have simple regimens, all oral, once or twice a day, that will be able to eradicate the vast majority of patients. But like HIV, there will be multiple regimens. I mean, in theory, you and I could be treating HIV because there's a bunch of once-a-day medicines. I just don't know all of them. I don't know which one to choose in which patients, and I don't really know what I'm supposed to do with the patient. So I would rather defer that to someone who knows more. So if you want to do this, then you're going to have to do all the learning. I'll stick to liver and let the ID guys do what they want to do.
Bob, a member of the audience wants to know how you feel about the warehousing issue, that is, saving treatment-naive patients until new regimens become available.
I think it depends on why they are warehoused. There is, inherently a desire of physicians, because the treatment is hard, to not do it. There's also a desire of the patient, because treatment is hard, to not do it. If the patient is the one who is going into the warehouse, I'm okay with it. I think there are better therapies coming out. If the patient is highly motivated to be treated and cured, and you're shoving them into the warehouse, I have a little bit more problem with that. In areas like New York, patients will usually speak with their feet and go elsewhere. But there are communities where patients are being systematically denied therapy. And that, I think, is a problem, because for some genotypes, we may have interferon-free therapy soon. For other genotypes, we may have to wait longer for interferon-free therapy. We don't know what the insurance, the reimbursement policies are going to be, and the availability issues. And so I think as I said, I think as long as we present the patients the data, the pros and the cons, in a balanced manner, without revealing our own conflict of interest, which is it's easier for us to put them in the warehouse, I think waiting for newer therapies is a reasonable option in most patients.
Dr. Brandt, thank you very much for a really spectacular discussion of this very important issue. And I would also like to thank Gilead Sciences, Boehringer Ingelheim Pharmaceuticals, and Vertex Pharmaceuticals for their support of this important educational series, in addition to educational support provided by the Centers for Disease Control and Prevention. Please remember to complete the quiz at the end of the session to secure your CME credit. My name is Dr. John Reines, and I thank you for joining us.